Evening, everyone. Welcome to another session of Masterclass in Critical Care Medicine, where we bring across interesting case presentations. And this week, we are going to discuss about a case with acute quadriparesis. And to moderate this session, we have seasoned examiners, Dr. Rajendra Vajrapasar, who is a senior consultant and HOD Critical Care Medicine at Care Hospitals, Malakpet. Thank you for joining us, sir. And we have Dr. Kaladhar S., who is also Senior Consultant and HOD Critical Care Medicines from Yashoda Hospitals, Malakpet. And Dr. Faizan and Dr. Jahnavi will be presenting this case. They are from Yashoda Hospitals, Malakpet, doing their critical care medicine fellowship. Over to you, Faizan and Jahnavi.
Looks like we are all from Malakpet.
Yes, somehow it is from Malakpet.
Somehow it is all aligned. Yes, yeah, you can start at Faizan and then.
Today we are going to discuss a case of acute quadriparesis.
Jahnavi, your voice is...
Yeah, can you be a bit loud or be closer to the mic, please?
Close to the mic.
So this is a case of 48-year-old female with complaints of fever since 20 days associated with nausea and vomiting, with generalized body pains which started since 15 days, with difficulty in walking since 15 days, which aggravated in the last 5 days, with paresthesias involving both hands and feet since 4 days, and weakness while lifting the hands above the shoulders since 3 days. So coming to history of presenting illness, patient was already 20 days back when she started having fever associated with nausea and vomiting, followed by generalized body pain since 10 days, for which she went to a local hospital 7 days back and got treated with IV antibiotics and came here with a worsening lower limb weakness. She developed progressive ascending weakness since 15 days, which initially started with lower limbs, which later progressed to the upper limbs over a duration of 1 week. The weakness in the lower limbs gradually increased in nature, and she felt difficulty in standing up since last 5 days. Similarly, the weakness in upper limbs also progressed such that she felt difficulty while lifting hands since 3 days. She had paresthesias involving all the 4 limbs, with no history of diarrhea, fever, abdominal pain, or any drug intoxication history. There's also no history of fall, trauma, injury to the head or spine, with no travel history or any particular sensory level as described by the family, with no bowel and bladder involvement, and with no history of any insect bites. Coming to the past history, there are no similar complaints in the past, with no known comorbidities and no history of recent immunization. Personal history, bowel and bladder were normal. Last bowel movement was 2 times, which was the day before. Normal in color and consistency. Urine output was adequate and yellowish. Diet is mixed, with no significant family history.
Coming to general examination, can we begin, sir? Coming to general examination, airway was patent with no dysarthria or dysphonia, and cuff reflex was present. Breathing was spontaneous, and circulation patient was hemodynamically stable. And coming to disability, patient was alert, oriented, and following commands. There was loss of power in lower limbs more than the upper limbs, with loss of deep tendon reflexes. And on exposure, there were no signs of any bites, rash, or vascular lesions. And coming to vitals, heart rate was 73 beats per minute. Blood pressure was 130 by 80 mmHg. Respiratory rate was 18 cycles per minute. SpO2 was 96%. And on room air, temperature was 98.6 Fahrenheit. And GRBS was 88 mg per deciliter. And coming to systemic examination, CNS inspection. On inspection, patient was alert and oriented, with difficulty in lifting limbs overhead and against gravity. There was no visible signs of ophthalmoplegia, facial symmetry, no signs of any scar marks, signs of trauma, or any bite marks. Coming to palpation, muscle tone was, muscles were flaccid, and strength, there was symmetrical ascending weakness from proximal to distal, as proximal more than distal, as described by the patient. and neck rigidity was absent, and there was no spinal tenderness. And on assessment of motor power, the power of shoulder while flexion 5 in bilateral limbs, and on extension the power was 4 by 5 in bilateral limbs, and hand grip of the patient was good. Coming to the lower limb motor power, the power of hip was 2 by 5 bilaterally, and knee on flexion the power was 3 by 5, and on extension it was 3 by 5 bilaterally. And coming to ankle, dorsiflexion was 4 by 5, and plantar flexion was 4 by 5 on evaluation. And coming to sensory examination, superficial senses, there was loss of touch and pain sensation, and deep senses, there was the joint sense, position sense, vibration were intact, and MRC score was less than 40, and superficial abdominal reflexes were normal, plantar reflexes were equivocal, and deep tendon reflexes were absent. Gait could not be tested as patient was not able to get up. And coming to cranial nerve examination, gag reflex was present. There were no signs of any facial asymmetry, and no loss of nasolabial folds. And palatal movement was present on asking the patient to say ah, and there was no visible drooling of saliva, no difficulty in swallowing. Patient was able to protrude the trunk without any deviation, and external ocular muscle movements were also normal.
Respiratory examination showed bilateral sounds equal and vesicular, respiratory rate of 18 per minute with SpO2 of 96 in room air with good cough, and single breath count is less than 18. On GI examination, abdomen was soft with no tenderness in any quadrant or no organomegaly. Cardiovascular examination was normal with S1 and S2 present with no murmurs. The blood pressure of patient was 150 by 80 mmHg and the pulse rate was 73 per minute. And coming to the radiological examinations, the whole USG of whole abdomen was within normal limits with chest X-ray showing right basal haziness. MRI of brain was within normal limits and MRI of spine was also normal. ABG, the pH was 7.49 with PCO2 of 31.7 with PO2 of 75 and bicarb of 23, and lactates were 0.94. Anion gap was 8. So patient was shifted to ICU for further evaluation and management in view of decreased single breath.
Dr. Jahnavi and Faizan, I think there are some comments like voice is too low. You go a bit closer to the system. So at this point, if we want to stop, suppose as a critical care physician critical care point of view, what are the important considerations for you if any patient coming with acute quadriparesis? Generally, 1, 2, 3, 4 points. Suppose if you look at it, these type of patients, what are those 4 most important considerations that you will think of in these patients when you approach to their time course of disease or otherwise history taking and all? What should be in your mind?
Initially, when the patient comes and when the patient comes with the following complaints, when there is any neuromuscular involvement, there should be a rapid assessment to check whether there is any signs of respiratory distress. So, with neuromuscular weakness, if there are any signs of respiratory distress, then immediately airway should be secured. And after that, we have to come to a single. We have to narrow it down. If it is a upper motor neuron lesion or a lower motor neuron lesion, or if there is any.
So generally, what happens this type of patient when you are approaching? Generally, 4 things that you look at. One is how severity is the illness and weakness. At that point, patient is coming too weak, the power is low. Those are the things, severity of illness, how it is progressing over a period of time. And next thing is whether there is any bulbar involvement, because that poses the patient at risk of aspiration. You have to look at it and address it as early as possible. Next thing is respiratory muscle involvement, because these patients who have the ongoing neuropathy, myopathy, or central nervous system, as you said, upper motor neuron versus lower motor neuron, invariably will be having involvement of respiratory muscles, and that assessment is very, very important. Next, then you have to find out the cause why it is happening. As you said, the cause can be upper motor, lower motor neuron lesions, and any other reason. Because addressing the cause definitely makes the patient better. So that is very, very important. So as you are telling in your presentation, we have to differentiate between upper motor neuron lesion versus LMN lesion. So how do you differentiate in these patients with weakness?
So in upper motor neuron lesions, sir, the tone of the muscle is very spastic, whereas in lower motor it is more flaccid. And in lower motor lesions, usually the reflexes are normal to low, whereas in UMN type of lesions, that we can see hyperreflexia. And in LMN, the lesion can start from anterior horn cell to the muscle, whereas in the UMN, it is from brain to till the spinal cord.
So, when you are clinically assessing, especially from the point of respiratory muscles, so what are the muscles that you assess?
There it can be divided into three groups of muscles. The primary diaphragm. The second group of muscles will be the chest muscles, and the third group of muscles will be accessory group of accessory muscles for respiration. So if there is an involvement of say 3, 4, 5, there can be diaphragmatic palsy, which will be quite evident by the efforts put by the patient, and also the pattern of paradoxical abdominal breathing might be present. And and coming to the thoracic muscles,
What are the different
for
conditions that can be there that which affect the diaphragm directly itself? What are the different neuromuscular conditions or otherwise any other conditions? How do you divide them?
Any cervical fractures involving complete transection of injury of spinal cord at the level of level above C3, C4, C5.
Okay, that is one possibility. Any infectious pathologies?
Yes, sir. Usually in diseases related to critical illness neuromyopathy, the involvement of proximal and respiratory muscles will be present.
Critical illness neuromyopathy may not be like directly related to the infection. Na? So that is over a period of time, the patient is there in your ICU, then they will land up. What are the like acute situations or otherwise maybe subacute situations? Sometimes patient can land up in typical cervical myelopathy, sometimes leading to severe diaphragm weakness, as you said, C3, 4, 5 routes if they are involved, the possibility will be there.
One possibility can be even in
It's all related to spinal cord.
Yes, sir. So in transverse myelitis also, if the
Yes.
level of lesion is above C3, then there can be involvement of the diaphragm and the respiratory muscles.
Yes, the patients can come with acute transverse myelitis sometimes. So these patients can have typical cervical spine involvement leading to sometimes severe acute respiratory distress because of the involvement of the diaphragm. So along with other muscles also. So any other, how do you like differentiate? Suppose if any patient just coming with acute quadriparesis, probably in your case, you had narrated some history before what happened. But suppose if they are coming with, so what are the, how do you localize the type of weakness depending upon from where, suppose if you take from the central nervous system point, from their point of that point to till when, until muscle, how do you say what are the different conditions that can affect these systems from above to down?
Yes, sir. So if any lesion that is affecting the brain, let's say the patient has presented with stroke, it usually presents with the contralateral weakness of one half of the body. Whereas if there is any lesion that is involving the
But what are the CNS, the CNS disorders that can directly present with quadriparesis? So we are basically involved in dealing with the quadriparesis. No? So hemiplegia and typical ischemic or hemorrhagic stroke cannot be like that. But which part of the brain, if it is involved, they can have acute quadriparesis.
Can be divided into cortex, lacunar area, or the brain stem cell. So if there is any lactar involvement, then there will be muscle weakness of the contralateral side there.
Generally, what happens is when there is a brainstem stroke, these patients are most likely that they will present with quadriparesis as compared to hemispheric stroke, one hemisphere or other hemisphere. So when any patient coming with quadriparesis, probably when you are thinking from the point of CNS, you have to suspect possibly brainstem stroke is one of the common possibility they present with. So next, from CNS down.
Next, coming to the level of spinal cord, sir, like I said, anything like transverse myelitis above the level of C3 can present with quadriparesis and with weakness of the respiratory muscles and the diaphragm. And then,
Yeah.
Like how is the presentation is also will also matter, sir. Like if there is weakness with the CNS involvement, then we have to think of CNS causes. Then if there is no neural involvement, then we have to divide into upper motor and lower motor. And in that too, if there is upper motor neuron with bilateral or unilateral paresis, based on that, again we can divide these illnesses. And if there is no involvement of the upper motor, then we have to check if there is any lower motor involvement, and if the presentation is bilateral or unilateral. If the presentation is bilateral with no neurological symptoms and lower motor neuron involvement, then it can be myasthenia gravis or Guillain-Barré syndrome.
So basically, you can divide them like suppose central nervous system involvement and spinal cord involvement and neuromuscular junction involvement and nerves like peripheral nerves involvement, neuromuscular junction involvement. Next, muscle itself involvement. Simple, suppose if you look at, as you were telling about myasthenia gravis, if it is only muscle involved like myasthenia gravis, or otherwise there may be simple acute polymyositis, dermatomyositis like autoimmune disorders. There can be severe viral myositis. There can be rhabdomyolysis. So suppose the summer season, heat stroke, where rhabdomyolysis, neuroleptic malignant syndrome. So these kind of conditions can lead to only myopathy and muscle-related issues. The same thing like neuromuscular junction. If you look at any patient coming with unexplained weakness, acute situation, and you may have to look at toxic injections also, something like a acute organophosphate poisoning, which can also present with this kind of quadriparesis. So you may be looking at the smell of, maybe it is subacute injection. Sometimes they may present with it. It is inhalational, suppose it is subcutaneous exposure. So you may not be exactly knowing the history sometimes, but they present, and you may have to send some pseudocholinesterase, and then it will point towards that possibly the patient might be having acute organophosphate induced poisoning, which might have led to the quadriparesis. That is one thing. But Guillain-Barré syndrome, yeah, it is most of the times obvious, as it in your case where the course of illness is over a period of time, it happened maybe 1 week and 10 days, something like that. So depending upon the onset and duration, progression, how it is aggravating, relieving. So these, the history of present illness, as we generally discuss, depending upon that, you can categorize these patients. And later, of course, will be corroborated by the laboratory features and all. But generally, you should keep in mind that where is the exact location of this disorder might be, generally from CNS down to muscle. That is how you have to generally approach. Rajan sir, anything from your side?
So in this case, what single parameter is worrying you about the patient's condition? Single parameter.
So the single breath count is less than 18, sir.
Single breath count is less than 18 seconds.
It is 18 seconds or 18?
96%.
18, sir, 18.
Okay, that is a single parameter that decides where the patient should be. Okay,
requires an ICU monitoring.
And you have told flaccid paralysis, right? Ascending
Yes,
with
sir.
acute onset to flaccid paralysis. What are the differential for acute onset to flaccid paralysis?
Sir,
Quadriparesis.
yes, sir. So the most common in this scenario, the most common causes of acute flaccid paralysis would be, one is Guillain-Barré syndrome, sir, and the second one, it can be hypokalemic periodic paralysis.
Voice is very low, unable to hear anything. You can turn the laptop towards.
Yeah, laptop, I think you can turn this way that.
So the differentials of acute flaccid paralysis would be, one is Guillain-Barré syndrome. The other one would be an hypokalemic periodic paralysis. We can see flaccid paralysis in myasthenia gravis, in Lambert-Eaton myasthenia, in infective disorders like tick paralysis, in diphtheria, in botulism, organophosphorus poisoning that is presenting as an intermediate syndrome. So all of these conditions can have flaccid weakness, sir, elemental.
Okay, so you have told there is no evidence of bite marks. Why you have specifically mentioned about it?
Yes, sir.
Any neuroparalytic snake bite or any tick bite can present as a quadriparesis, sir.
Okay, if any tick bite is there, what is the treatment?
So if any tick bite is there, we usually start with doxycycline, sir, which has a doxycycline. We have another options like azithromycin can be given to the patient.
Tick to be removed. So soon the patient will get better. Okay. Any other peripheral neuropathy you can think about? Acute condition. Very rare, but because
porphyrias can also present as with this acute flaccid weakness, sir. Rare conditions would be acute intermittent porphyrias, sir.
Porphyriasis, acute porphyriasis also.
Yes, sir.
Can cause this type of paralysis, peripheral neuropathy. Okay.
What is the typical presentation of acute porphyria, intermittent porphyria?
Abdominal pain will be there, sir. That will be the clenching clinical sign to differentiate it from other flaccid paralysis.
Abdominal pain and
the neurological involvement can be anywhere from weakness. The patient can also have seizures, progressing to refractory seizures. Coma can also be seen in acute intermittent porphyrias.
So you mentioned in your ABG that can you interpret the ABG?
It is a normal. There is a respiratory alkalosis, sir. pH is more than 7.
The typical pattern how we interpret as a student. Can you please interpret like that?
pH is 7.49, sir, with the bicarbonate of 23.8 and the
first and foremost step. The first and foremost step in any ABG.
Validity of ABG, sir.
So how do you check the validity?
6 minus logarithm of bicarbonate into
that will become too complex to check at the bedside, isn't it? There is a simple equation. (24) into PCO2 by bicarb. So that is how you check generally the validity. So I think next time onwards, I think probably you check the repeated times, then you will understand how the validity is important. So yeah, other than that, how do you interpret at this point this ABG?
So the pH is 7.49, sir, and bicarbonate is 23.8 with PCO2 of 31.7. And PO2 is 75. PO2 is 75, sir. So there is a respiratory alkalosis, primarily respiratory alkalosis, sir.
Can you rely upon ABG in patients of this acute quadriparesis, where possibly looking at respiratory muscle involvement is there until respiratory arrest happens? Can you depend upon that? Like 6 hourly ABG, I will do and check if it is worsening. It means that patient is worsening. Can you rely upon that, or is it a clinical assessment, which is better?
No, sir. Assessing bedside respiratory function will be better than relying on ABG, sir, because
Why
ABG
so?
can be
Hmm.
because that the PaCO2 will keep on rising, but it can get compensated and the ABG can still be normal because the patient might be hyperventilating to wash it out. So until the PaCO2 rises to a certain value, and alveolar gas equation gets hampered, then only hypoxemia will set in and acidosis will set in, sir. So we can't rely on it.
So even though the tidal volume decreases because of the weakness, the patient will try to compensate with increasing respiratory rate to maintain the minute ventilation. So most of the times it may look normal until to the point when the respiratory arrest is going to happening, like imminent respiratory arrest. That point of time, probably the CO2 may go up. That is the reason probably you will not depend upon ABG in these patients. So, what are the other parameters that you look at in this patient? You monitor at the bedside in respiratory assessment of these patients, or otherwise, you can say the patient is worsening, probably needs intubation. So, when do you think? How do you assess that?
So the single best test to do bedside would be the single breath count test, sir.
Okay.
That gives us uh, that will help us to identify the patient that requires close monitoring because it's easier to do and it also reflects the FVC.
Other than that, any other parameters you know of?
They're assessing the pattern, the respiratory rate of the patient, and if the cough reflex is good or not, if there is any onset of bulbar weakness,
Oh,
filling of secretions.
Those indicate the bulbar weakness. Basically, you are looking at the bulbar weakness where there is a difficulty swallowing, difficulty phonation, pulling of secretions, cough is not good. These are indicative of possibly bulbar weakness where you may think of early intubation to prevent aspiration pneumonia.
Yes,
But
sir.
bedside respiratory muscle function assessment in terms, as you told, like diaphragm,
Yes.
intercostal
Yes.
muscles, or accessory muscles, there, yeah, clinically one thing you look at nasal flaring happens, paradoxical breathing may happen. But other than that, single breath count, one thing you told. But other than that, there is something called as 20-30-40 rule. So what is that?
Yes. So the 20-30-40 rule of GBS is the patient can be having respiratory insufficiency if the FVC is less than 20 ml per kg and the maximum maximum inspiratory pressures are less than 30 and the expiratory are less than 40, sir.
Practically, anytime you assess that?
MIP we have assessed, sir, but not FVC, sir.
How it will be assessed generally, the bedside generally? Most of the ICUs, I don't think so. They monitor this. Theoretically, they speak, but most of the times they may not assess. But yeah, as you said, probably sometimes the patient is intubated, we do. But bedside before intubation, how do you assess?
By using spirometry, bedside spirometry, sir.
Yes, there are specialty designed spirometries, handheld spirometers. They can give this MIP and MEP. So forced vital capacity also. So those, if you have generally procure, that will help.
Yeah, Faizan, can you estimate vital capacity FVC with single breath count test? Any formula or anything you know?
Yes, sir. If the single breath count is more than 21 seconds, then the FVC will be more than 20 ml per kg body weight, sir. So if it is less than 21, then it will be 15 to 20 ml per kg body weight.
It's usually SBCT into 100 gives the FVC. Then you have to divide it by the patient's weight in kgs. Then that will give FVC ml per kg. Okay, simple correlation.
We'll go forward, sir.
Yeah, please.
So the provisional diagnosis that we have come to after the history and the general physical examinations are, one is because it is acute onset, we have thought of GBS, myasthenia gravis, Lambert-Eaton myasthenia, critical illness neuromyopathy, dyselectrolytemias, hypokalemic periodic paralysis, botulism, diphtheria, tick paralysis, inflammatory myopathies, and polio.
Coming to
go back to that provisional diagnosis. So, in your case, what is the most likely diagnosis? How do you rule in, rule out, like to most likely diagnosis in your case?
Okay, sir. So here, in our case, the history started 20 days ago. It is acute in onset, and the weakness has progressed from lower limbs to upper limbs, which suggests an ascending type of weakness. Our first differential would be Guillain-Barré syndrome. So myasthenia and Lambert-Eaton can be also present with proximal muscle weakness, but they have a fluctuating course. Usually myasthenia patients, they present with complaints of fatigue towards the end of the day, and usually present with the ptosis and other ocular features, sir. And critical illness neuromyopathy also has a proximal weakness, but here the patient did not have a critical illness before that, and he did not have a history of, she did not have a history of long-term hospitalization, so we can rule out critical illness neuromyopathy. In dyselectrolytemias, both hypokalemia and hyperkalemia, hypocalcemia and hypercalcemia, and hypophosphatemia, all of this can present with muscle weakness. And in hypokalemic periodic paralysis, the weakness is usually fluctuating in course. It's never constant. In botulism, the usual presentation would be involvement of cranial nerves, and patients will have history of severe abdominal pain and diarrheas. Diphtheria will also have acute onset, that is usually after 2 weeks after an acute diphtherial attack, and the weakness in diphtheria is usually descending. In tick paralysis, as we could not find any bites on general examination, so we can rule out tick paralysis in this condition. And in inflammatory myositis, usually they have a long course. They have a long course. It starts with proximal muscle weakness and then involving the distal muscles. And polio is also can be possible, sir. Because polio involves the anterior horn cells, and they can have flaccid paralysis.
Suppose a patient sustained some injury and wound, and then they presented with possible acute quadriparesis. What other differential can you have to keep in mind?
Trauma,
spinal shock syndrome. Spinal shock syndrome.
No, he just had a wound on the leg, had sustained some injury wound on the leg over a course of another 5 to 6 days, presented with acute quadriparesis and any infection.
Tetanus.
Yes. What is the typical posture of tetanus?
Opisthotonus.
It's not that common nowadays because of the immunization and all, but previously it used to be common, but still there are some sporadic cases that come, but it is most of the times devastating illness. The course of the disease is very bad, like most of the mortality is very high, but still sometimes this also we have to keep in mind. So what inflammatory myopathies you will suspect?
Even dermatomyositis, inclusion body myositis, there can...
Any drug-induced myopathies?
Drug-induced, yes, sir. Amiodarone-related proximal muscle weakness, or chloroquine-related proximal muscle weakness, or gold, but
most common. These are not that common, whatever you told, amiodarone and chloroquine. Most commonly, it is used.
Sapsone.
Statins, no? The most commonly used are
Statins.
statins. Statins can lead to sometimes myopathy. We had some patients. So sometimes it can lead to severe myopathy. Yeah, go to the next.
Coming to the course in the hospital, as soon as the patient was shifted to ICU, bedside focus was done, which revealed IVC diameter of 1.2 centimeter with collapsibility index of 40%. And heart screening was done. Chambers were normal, contractility was good, and there was no regional wall motion abnormalities, and lungs were showing A profile. And IV fluids were started at the rate of 70 ml per hour, and urine output of the patient was 40 to 50 ml per hour that day. And nerve conduction study was done, and CSF analysis was also done. And the laboratory parameters came out to be these are the laboratory
Faizan,
parameters.
if I have to interpret, so what was your intention looking at the bedside focus, specifically targeting IVC diameter collapsibility index? What was your thought process behind that in this patient specifically?
Patient is not able to stand from a very long period of like 5 days. And she is dependent on some other. So hydration might also be hampered. And
But she was not hypotensive. She was not tachycardic.
yes, sir.
So what is the reason? And she's not even hypoxic also. So why do you think you have checked it? So it has become a norm for any patient you check. It's not like that. So see, any patient who is having those things, then you check. That makes sense. But other than that, I don't think so. There is any sense looking at this because you are not suspecting there is no hypotension, there is no hypoxia, you are not suspecting any heart illness. And so what is happening is nowadays, like any residents like you, not only you, they most commonly focus. That's becoming a norm. So, but generally, you have to look at in the context of the patient and whether it is needed or not needed. That's the point generally. So, okay.
Yes, sir. And laboratory parameters, hemoglobin was 8.1, total counts were 7,000, and platelets were 3.83 lakhs. Blood urea nitrogen was 10.28, creat was 0.5, sodium was 134, and potassium was 3.8. Total bilirubin 0.7, SGPT and SGOT were 23 and 22. PTINR was 14.1, and INR was 1.03. Urine examination revealed there were no pus cells, and nitrate was also negative.
So you told all these investigations, na? So
yes,
when you are looking at this patient, you are in ER with this patient, and you are asked to send the investigations. How do you streamline your workup towards approaching this patient? Generally, what is the workup that you send?
Complete blood. I would like to send a complete picture, sir, including hemoglobin to rule out if there is any anemia or any nutritional deficiencies, and total counts if there is any ongoing infection. As a patient was already having these motor symptoms, there could also be, and chest X-ray also revealed there was some haziness. There will be a chance of aspiration pneumonia, which is not quite evident clinically, and PTINR to look for any bleeding tendencies because they can be hemorrhagic stroke or in.
So basically, any patient you are approaching like this, you have to divide them into routine investigations and specific investigations. So whatever you told is routine. You want to look at the basic what is happening. Suppose complete blood picture, or otherwise renal function test, or liver function test, or coagulopathy because there was some infection. These are all routine investigations because the patient is coming to ICU. You want to look at any abnormality. What are the specific investigations in this case pertaining to this case that you will send? You need some diagnosis.
CSF analysis can be done for this patient, sir. to rule out any meningoencephalitis syndromes.
Okay. Do you suspect meningoencephalitis? It was not in your original diagnosis, if you remember. Then why
Yes,
do you are contemplating to do CSF at this point to rule out meningoencephalitis when it is not there on your original diagnosis?
CSF here in this case, as the history is suggesting of ascending paralysis, sir, we can confirm the diagnosis of GBS using any cytoalbuminological dissociation. So usually, if the protein is high with in the background of normal WBC count in the CSF, then
So the basically you mean to say you will look at albuminocytological dissociation. So if you look at the pattern of answering in your pattern of, if you introspect yourself, the second point, whatever it is there, albuminocytological dissociation should be told first, rather than again you are deviating yourself telling meningoencephalitis, because in exam this is what happens. You will have very short time, maybe 20-30 minutes, but you deviate so much. Suddenly you deviate. You are telling in your line of something, and you deviate from that line, it will go to somewhere. So what is happening with the patient and what is in your mind when you are sending that investigation is very, very important. So, so the first point, whatever you told, generally should not be told that way. So, albuminocytological dissociation that you look at. So, in the context of GBS, what is the role of CSF?
So in the context of GBS, sir, in GBS usually has an albuminocytological dissociation because the primary pathology of GBS is a polyradicular neuropathy. Whenever the radical is damaged, we have elevation of proteins. But the cell count is not increased. So that is the basis of
Do we
that
need to
GBS has.
do we need to do CSF in all patients or not? What is the protocol?
So doing CSF will give us better evidence, sir. If you are unable to pinpoint it to a cause, or if the history has overlapping features, then doing doing a CSF analysis would give us a better picture, sir.
So basically what happens is most of these patients generally undergo CSF analysis, and most of the protocols also say, the guidelines also say that CSF should be performed in all cases of GBS to rule out other possibilities. But generally, at which time course of disease generally you do it? Time course?
After 1 week of the onset of
In the
disease.
second week of illness, that is when
weeks.
it is most evident that albuminocytological dissociation is most evident. So that is the reason second week is the best. But in this case, do you think at this point you do, or you wait some time?
Yes, sir. This is the correct time, sir. Actually, patient had the symptoms, started having symptoms 14 days back. She went to another hospital, was taking treatment, and then she came around 13th to 14th day of her illness, sir. So
you feel the patient is well
the
within
illness,
the second week of illness. I think right
Yes,
away
sir.
you do CSF, probably you will get the information whatever you need. So I think
Yes.
that's fairly okay point. So that is one thing. CSF. Next, any other things that you do? Specific investigations we are talking about.
Nerve conduction studies would give us better pictures, sir, of the
Okay.
pattern of the weakness. And if we are dealing with a demyelinating type of the weakness or an axonal type of weakness, so that it helps in further narrowing down the diagnosis.
Okay. Anything, sir? Arjun, sir, you want to ask?
So do you want to look at the metabolic components like thyroid? Do you want to do thyroid test?
Yes, sir. Hypothyroidism also presents with, yes, sir. Vitamin D deficiencies, hypothyroidism can present with proximal muscle weakness.
Thyrotoxic myopathy is also possible with flaccid pyrolysis. Okay.
Endocrine disorders, yeah, you have to look at, like as you said, thyrotoxic myopathies, or otherwise possibility of adrenal insufficiency sometimes they also present with that. And as you were telling initially, the electrolyte disturbances like hypophosphatemia, patient might be starving sometime, and again um, the feeding was started, they land up in acute quadriparesis. What happens? what I'm talking about? That is called
refeeding syndrome, sir.
Okay. So those also are possibilities. Sometimes phosphate and are looking at them also is important. So finally you took us towards GBS. So what is the pathophysiology of Guillain-Barré syndrome?
Another important history
Ah,
is
sir.
history of vaccination.
Yes, sir.
Okay. If any vaccination is done recently, that can also cause polyneuropathy and GBS, drug-induced vaccination.
Usually the rabies vaccination history we do ask. Most common.
So what is the pathophysiology of GBS?
So in GBS is the acute immune-mediated polyradiculoneuropathy. It happens because of the molecular mimicry, sir. Usually the antibodies that are directed towards a microorganism like like bacteria like Campylobacter jejuni, the lipo-oligosaccharide component of the Campylobacter jejuni. So it has a structural similarity to the myelin. So the antibodies that are formed against the bacteria go and start attacking the axolemma or the myelin sheath, resulting in the activation of the complement and the macrophage activating system and degrading of the myelin or the axolemma.
Correct. Okay. So what are the antecedent causes? Generally, these patients land up, as sir was also telling. So what do you think are the different prodromal illnesses? Then the patients will land up in GBS.
So in bacteria, usually a prior 4-week prior history of infection with Campylobacter jejuni or the Mycoplasma pneumonia or viral infections such as hepatitis A, hepatitis B, E, and the cytomegalovirus, Epstein-Barr virus, HIV. All of these infections, they do have a role in the pathogenesis of GBS, sir.
So influenza illness is also one of the thing where after a patient got influenza illness, the patient can land up in molecular mimicry and leading to GBS. So the more and more studies and the recent updates are regarding vaccination we were talking about. So if you give vaccination, you will be preventing the influenza illness. In a way, if you are preventing influenza illness, the patients landing up after influenza illness in GBS, you are preventing. But the vaccination itself causing GBS is one in generally a million. That's what the epidemiological studies say. So extrapolating all these results, they say the vaccination causing GBS is negligible incidence of GBS. Rather, by giving vaccination, you are preventing the illness of something like an influenza, where you will prevent more cases of GBS. So that is the more and more evidence that's coming up regarding vaccination. But all other, like especially the Campylobacter jejuni is the most commonly implicating organism. I think recently, previous year, we had in Pune, where there were cases of multiple GBS cases and associated with the diarrhea. Even they looked at epidemiologically, looked at the sewage samples, looking at Campylobacter jejuni was isolated in some samples. So that is the most common organism that precipitates the GBS. So, what is the diagnostic criteria of GBS?
So the weakness should start around 2 weeks after the illness and should not progress beyond the 4 weeks. Usually, it will be acute phase, and there will be paresis associated with the areflexia, sir. So there is a criteria called as Brighton's criteria, which gives a clinical which helps us to evaluate clinically and give a diagnosis. It has got level 1, level 2, and level 3 criteria. In level 3, there will be motor paresis, areflexia, and no absence of any alternative diagnosis, which will be confirmed with a nerve conduction study or CSF analysis. If both CSF analysis and also nerve conduction study is positive, then it is considered to be level 1.
So, regarding nerve conduction studies, as you were telling, initially the patient presented and nerve conduction studies not much pointing towards GBS. Will you still consider the diagnosis of GBS, or what is your approach at that point?
We can repeat the nerve conduction studies, sir. If after 1 week we can repeat and.
So that is the basic approach. When initially they are not much positive, sometimes it is the commonly observed thing. Sometimes they may not be that much picked up. So generally you repeat them in the second week or after 5 days to 1 week, you may still able to. But if it is clinically diagnosed as GBS, as you were telling about the ascending paralysis with the reflexia and all, very much pointing towards GBS, you'll not wait until nerve conduction studies come positive and you'll go for instituting them. So what are the generally nerve conduction study findings that you get in GBS?
Based on if the illness is demyelinating or axonal, so if the disease is demyelinating, then there can be increased in latency, sir, and with decrease in velocity, and suggesting there is demyelination that is happening. And if the compound muscle action potential, amplitude of compound muscle action potential is decreased, then it represents a axonal involvement. And so in variants like AIDP, there will be increase in latency and decrease in nerve velocity, whereas CMAP will be towards the normal side, and the sensory nerve action potential will also be normal. Whereas if the variants are acute, if it is AMAN or AMSAN, which is acute acute motor axonal neuropathy or acute motor and sensory axonal neuropathy, then there will be the latency and the velocity will be normal towards the normal side, whereas the compound muscle action potential, the amplitude of it will get decreased. And in sensory variants, the snap can be non-recordable. And sometimes there can be overlapping between all AIDP and with AIDP with the secondary axonal involvement, which can again decrease the amplitude of combined motor action potential.
So what is the difference between F wave and H reflex? Any idea what is generally they say now when neurologist comes at the bedside, you will be discussing about nerve conduction studies. So they say sometimes F wave latency and all. What do you think? What are the differences between them?
So, sir, in a nerve conduction studies, what the F wave does is we first stimulate the nerve with a maximum amplitude. So, usually the impulses should travel from the antidromically, sir. So, that is the usual pathway. But when we give a supramaximal stimulus, there will be some impulses that travel orthodromically to the spinal cord. And once they reach the anterior hornsel will give us an impulse. That is the F wave. And it has different shapes and morphologies basically.
Yes.
So what happens in the GBS is the F wave is reduced. What we normally see in GBS.
What variant generally will have F wave latency?
In AIDP variants.
So demyelinating variant generally
demyelinating variants do have that. And whereas the H wave is the equivalent to the ankle jerk, sir. So we test
looking at sensory examination, sensory nerve.
Yes, sir. So we usually check at the S1 nerve root and the tibial nerve root, and that's equivalent to a reflexor. So in GBS, because the reflexes are low, the H waves are absent.
Yes. So what are the different variants of GBS?
So the most common variant is the AIDP, sir, which is the acute immune mediated demyelinating polyradicular neuropathy. The other variants are the MAN, which includes the motor axonal, AMSAN, which is motor and sensory, with pure motor variants, pure sensory variants, pan dysautonomic variants with Bickerstaff and encephalitis, the Miller-Fisher variant, and there is a
What is Miller-Fisher variant?
Miller-Fisher is the triad of ataxia, ophthalmoplegia, and areflexia, sir.
Bickerstaff is how the patient with Bickerstaff encephalitis can present.
So Bickerstaff encephalitis will have CNS involvement, features of CNS involvement, sir. So they can also have seizures.
It's basically brainstem encephalitis.
Yes.
So the CNS involvement signs like patient having altered sensorium or otherwise seizures is most likely possibility along with ataxia and all. So any other variants that you know of?
Cervicopharyngeobrachial variant, sir, where they're present with the bulbar weakness and the facial nerve involvement and ophthalmoplegia.
Without any limb muscle involvement, they will have only this cervicobrachiopharyngeal involvement. So typical have landing up in bulbar weakness and aspiration kind of situation. Yeah. Next. There are other variants which are not very common, pure sensory form, pure motor form, something like that. So, pathophysiology point of, if you look at the structural component of the nerve, so demyelinating versus axonal, what happens exactly? Demyelinating.
So demyelinating is the damage to the myelin sheath, sir. Whereas the axonal variant, predominantly the damage is done at the nodes of ranivul and the adjacent paranodal myelin.
Okay. So yeah, basically the axolemal injury is severe as compared to demyelinating, because demyelination where remyelination can happen, but axolemma injury, axon especially, it is cut off. These type of patients will have poor prognosis because they may be having persistent weakness. Sometimes if it is so severe, they may have ventilatory, they may be on ventilator dependent and all. So that is the reason I think demyelinating variant will be a better definitely to treat the things. So at this point, suppose these patients, intensive care perspective, what other things that you will be worried, especially a patient with GBS to the extent getting intubated comes to your ICU, what are the things that you keep in mind and monitor them closely?
There can be autonomic involvement in patients of GBS, sir. So there can be dysautonomia, which can lead to either increase in heart rate or bradycardia, or hypotension or hypertension. So the patient can go either way, sir. So if accordingly we have to be monitoring the patient, and we have to treat whatever the autonomic dysregulation is. And there is high chance of because this is an ascending paralysis and slowly respiratory muscles get involved, so we have to check a single breath count test periodically and
so
assess.
Suppose there is a patient who is on ventilator, as you said, dysautonomia or autonomic dysfunction is most concerning for you as a ICU physician, and this patient is having tachybrady, hyper, going deep, suddenly heart rate going to 180 and coming down to 50, 40, and patient hypotension is happening. So how do you manage this patient? What are the things that you keep yourself prepared and keep everything ready in the event that patient will get further, like anytime they may go bad? So what are the things that you keep organized?
So for bradycardia, I would like to keep ready anticholinergics, sir. So if there is any bradycardia, then I would like to give anticholinergics. And then if there is any tachycardia, I should be ready with the beta blockers, sir. And
which beta blocker you prefer?
Labetal also.
Is it so? Because he's having hyper, na? It's just like that. It's going up and down.
Esmolol short acting should be.
Generally, ultra short acting, something like esmolol is a better option. So next, any other things you keep ready?
For hypertension, we can use both. If there is persistent and continuous hypertension and hypo patient is going, then we can be ready with NTG and also NORAD infusion, sir. So accordingly we can titrate and target the mean arterial pressure.
Sometimes you have to keep ready even the pacing. So sometimes they may need transvenous pacing also. Along with that, you may have to keep your defibrillator also ready. This way, that way it can happen. Defibrillator will help you in even transcutaneous pacing also. So these patients, just like that, I have seen one patient recent, like maybe 1.5 years back in our ICU. We tried everything. Unfortunately, we lost that patient having this way, that way, going up very labile hemodynamics, especially heart rate and blood pressure point of view. So we kept everything ready, but we couldn't much. She couldn't give much time. So these patients go down just like that. So you keep everything ready. So prepare for even transvenous pacing and all sometimes. So next, so the treatment point of view, I think we discussed the approach to management of what can happen, different complications. So definitive treatment point of view, what are the things that are there, evidence for GBS?
So the most common treatment modality that we are using as of now is immunoglobulins and the plasma exchange. So either of the one we can use, both are equally effective.
So what is the most common pattern, clinical practice point of view? What we are using among those two?
IVIG, sir.
So why IVIG is preferred over plasma exchange?
Easy to administer, sir, one thing. And the complications are less when compared to plasma exchange. And
any other things? What are the complications of IVIG? What are the complications of plasma exchange?
So for IVIG, the most common complications would be anaphylaxis, more risk of thrombosis, and
even meningitis can occur, sir.
Because those are all possibilities. The most common complications, as she said, there is possibility of anaphylaxis. In which subset of patients the possibility of anaphylaxis is more?
IgA deficient patients.
Generally, IgA deficient patients will land up in anaphylaxis. Next, as you said, I think prothrombotic state can be there. Viscosity may increase and it can lead to prothrombotic state. Next, what is the dose?
0.4 mg per kg body weight, sir, per day, divided over for 5 days.
Total?
5 days, sir.
Total dose.
2 gram per kg body weight, sir, over 5 days, sir. Either it can be given in 5 divided doses, or some school of thought says that they can be divided in divided into over 2 days. 2 days.
Which is better?
So giving it over 5 days would be better, sir.
Why so? Why do you think so?
Because
there can be transfusion related the fluctuations if the patient is of a younger age, or if the weight of the patient is lesser. So even though when the patient might be recovering, the IVIG related deterioration can also occur. So the paresis can also get worsened.
Yeah, it is not like that. The thing is, most of the time, the tolerance. See, you give IVIG, suppose 1 gram per kg versus 0.4 gram per kg. The amount of the fluid you are infusing to the patient will be definitely go up when there is 1 gram per kg. Suppose a young patient, not much of premorbid illness or something like any CKD or otherwise a possibility that patient gets volume overloaded because of this. Then generally it's better to go for 0.4 gram per kg per day over a period of 5 days. Suppose a young patient who is not having this illness, you go for directly 1 gram per kg over 2 days. So the efficacy point of view, not much difference across different studies. It all convenience and looking at it is another one of the complications also, transfusion associated overload. So when you give the lot of dose at the same day, the possibility that the patient land up in overload. So that is the thing. Next, what are the complications of plasma exchange? And how do you perform?
40 to 50 ml per kg body weight, sir. And over 5 sessions, the one with every alternate day. And
what is the reason for performing every alternate day? Why can't we perform every day?
So whenever we are doing plasmapheresis, only 60% of clearance will be there, sir. So after getting this clearance, whatever whatever the antibodies are, they will recirculate, and then they can come into plasma again. So that way it will be efficacious.
So here in Guillain-Barré syndrome, we are targeting IgG, sir, which predominantly has the extravascular distribution rather than the intravascular. So that is why we do repeated sessions to at least target 60% of the antibodies.
Repeated sessions, but alternate day.
Yes, sir.
So as Dr. Faizan was telling, and you are telling, it is more of extravascular distribution rather than intravascular. So when you are doing one session, probably you remove all the intravascular IgG, but the extravascular IgG, nothing but the autoantibody of IgG, will redistribute to the intravascular compartment maybe over a period of 24 to 48 hours. Generally, they say 1 to 2% of IgG comes from extravascular to intravascular. So at least more than 60% of the intravascular IgG is there, then you do a plasma exchange, then it is more efficacious. So if in that sense, if you look at 48 hours, it may be coming around to 60%. If it is 1 to 2% per hour, then it will be more efficacious. That is the reason generally we plan over a period of 10 days, 5 sessions. So they looked at between 5 sessions versus 10 sessions also in some studies. Not much useful, because 5 sessions itself will remove all the possible autoantibodies, something like IgG. So most of the times it will be efficacious. So what is the cost effectiveness of both of these therapies against IV or GBS?
IVIG may cost up to 1 lakh for every 5% ampule, sir. So it can go up to like 3 lakhs per session.
You know exact cost of IVIG? Then you will understand what is 1 5-gram vial, or sometimes 10 gram also comes, but generally 5 grams that we use. So what is that 1 vial cost? You should know. So depending upon that, if you look at, most of the times it comes around 4 to 5 lakhs in between the cost. What about the plasma exchange?
Plasma exchange each session would cost us around 50,000.
Varies different institute, but generally it is around 40 to 50,000. It is also. So 5 sessions leads to definitely a 1 lakh bit less on this side. The plasma exchange scores better cost wise. But considering the complications, like you put a device, possibility the CLABSI, sometimes you do plasma exchange, you remove the other immunoglobulins which are helpful in infection prevention, the possibility that the transfusion related and otherwise citrate related. So these most of the times they use replacement solution as albumin. Generally will not be much problem, but the complications may also be there, especially infectious complications are more. Because of that, if the patient stays more in ICU and all, the possibility that the cost will be not much of difference. And more, the patient safety point of view, nowadays, like IVIG scoring better because it is simple to administer. These all complex device related and all complications will be prevented. But nevertheless, most of the studies, like very good randomized studies say, head-on-head comparison, the efficacy point of view, both of them are equally efficacious. So that is the way. So then, what do you think? Suppose a patient you have given the IVIG dose, patient did not show any improvement. What do you do?
So treatment-related failures can happen in GBS, sir, in which there will be disease progression beyond 2 weeks and there will be inadequate response. In those kind of situations, we can either continue with IVIG, or to in an increased dose, sir.
So you mean to say you have you have completed the course of 2 gram per kg, and then you again restart IVIG again 2 gram per kg.
Or else we can also switch to Plex, sir. So if you are on IVIG and not having adequate response, we can switch over to Plex in treatment-related failures.
Faizan, any thoughts on that?
We'll continue with the 2 grams per kg. We'll repeat the same dose, sir. Either by increasing, we can also increase the dose.
So this is what happens sometimes. Any patient, like after giving the initial 2 gram per kg dose of IVIG and the patient is not improving, there is no rationale to give again 2 gram per kg. And Jahnavi, as you told, you can think of plasma exchange. It is not recommended because IVIG may stay for longer periods of time. Sometimes the effect may not be immediate, but over a period of time, the patient may improve because of the IVIG mechanism. But if you do plasma exchange, you will tend to remove all the IVIG what is there in the patient system. So generally, it is not recommended after IVIG. If the patient not improving, you should not do plasma exchange. And generally, repeating IVIG is also not recommended, generally up to 2 weeks. But there is an entity called as treatment-related fluctuation. So we had one patient recently, around 6 months back. So after he improved well with IVIG, was unable to walk and mild respiratory involvement was there. He improved very well with initial IVIG dose. But after 3 weeks, he again presented with more weakness. That is when we tried again second dose of IVIG. There are some studies say maybe after 2 to 3 weeks, suppose the patient initially improved and again coming with weakness, which is called as a treatment-related fluctuation, TRF. In these patients, probably you try again the second dose of IVIG. But initial periods, if not improving, you still wait. And but if the patient received plasma exchange initially as a initial treatment of choice, then is not showing improvement, probably IVIG can be tried in the second instance. But not the other way around, something like IVIG and then you do plasma exchange, which is not helpful because IVIG efficacy, whatever it's going to be there for some time, will be negated. So that is the reason you'll not do plasma exchange. That is the general, the evidence guidelines say. So Rajendra sir, anything you want to ask?
Yeah, that's what, you already mentioned. There is no need for plasma pheresis after IVIG, and IVIG repeat need not be done. And the other thing is with IVIG, sometimes so hyponatremia, hemolysis, AKI, all these are also possible. So we have to be very carefully watching for this.
So I think complete your presentation. Then I think we stopped here only. Day one itself we discussed everything. Yeah, go forward.
Sir, so the NCS was done, sir, and in NCS there was increase in latency and also decrease in amplitude in motor component, and with decreased nerve root, nerve velocity, nerve conduction velocities, and the sensory and the sensory nerve action potential was diminished. It was non-recordable, as can see here in the peroneal nerve. And these are the values which are representing increase in the latency and a decrease in the amplitude when compared with that of the control. There was increased latency and decreased velocities, which was suggesting of demyelinating disease, and there was decreased compound muscle action potential, which was suggesting axonal involvement, and the sensory nerve action potential was non-recordable. And so the coming to the NCS findings, there was suggestion of acute inflammatory demyelinating polyneuropathy with secondary axonal involvement versus acute motor and sensory axonal neuropathy. Coming to the day 2 of illness, patient was hemodynamically stable. Continuing with the day 1, patient was hemodynamically stable, and EGRIS score was calculated. So the days between the onset of weakness and hospitalization was less than 3 days in the previous hospitalization. So score 2 has been given, and there was no evidence of facial or bulbar weakness at the time of admission, 0. And MRC sum score at hospital admission was 36. So score 2. So the total exit score was 4, which suggested that there is a moderate risk of respiratory insufficiency. And then modified EGOS was done at the day 7 of illness, which came out to be 8. So this indicated delayed recovery and the moderate severity, the prognosis. Bowel and bladder function was normal. There was no episode of fever, tachycardia, or hypotension. And IVIG was advised by neurophysician 2 gram per kg body weight, which came around to be 180 grams, as the patient weight was 90 kgs, and was given over 5 days. Coming to the day 2, patient status remained same. There was no worsening of respiratory distress, and single breath count test was 20. And CSF analysis report also came, which suggested cytoalbuminological dissociation with total counts of 4, and protein was 136 milligrams per deciliter. And day 1 of IVIG, 40 mg of IVIG was given slowly. And day 3 to 4, there was no significant change in patient muscle power, so which remained 2 by 5 in the lower limbs and 3 by 5 in the upper limbs. And patient was hemodynamically stable with no signs of autonomic dysregulation. Bowel and bladder function was normal, and there was no signs of autonomic dysfunction. So, and the day 2 of IVIG, 40 mg was given. Day 3 and day 4 and 5 were also not significant. The patient remained status quo, and the single breath count test has improved to more than 21 seconds. And as the patient had economical constraints, they have requested to get shifted out of the ICU with the risk explained, and they were shifted out. And on day 5 of IVIG, it was given in the room side, and then patient had decreased responsiveness with increased respiratory distress. And Medcall was done. So SpO2 was 86% on the room air, and patient was connected to oxygen. And GCS was assessed. It was E3, V3, and M4. And we have intubated the patient in view of threatened airway. And she was taken to MRI brain to rule out any acute cerebral events. And then it came to be normal, and she was shifted back to ICU. And ABG was done at the time of MET, which suggested respiratory acidosis. And the next day, the patient sensorium improved, and she was continued on the pressure support mode of ventilation. ABG was normal, and family was prognosticated regarding the risk of delayed recovery and the need of continued mechanical support, and the potential need for early tracheostomy. But in view of economical constraints, the patient was taken lungs.
Anything, sir?
Yeah, so basically this patient SBC is marginally improved, and maybe because of financial constraints, patient might have been moved to ward. At this juncture, what you advise to the nurses to how to monitor this patient in wards?
They should be clearly explained about the use of the bedside evaluations. A single breath count test should be done, and they should be they should be taught how to do this, so that they can go periodically and can do the assessment of the patient. And they can intermittently go and visit the patient to check how is the sensorium. And we should also educate the family attendants to inform as soon as possible if there is any deterioration in the clinical condition of the patient.
Yeah, with this patient, only one test we are monitoring. That also how frequently we need to monitor, we have to be very clearly mentioning to in the file. And if any MET team is there, the MET team also should be monitoring the patient very closely. If possible, spirometry, because most of the validation done with spirometry parameters like maximum inspiratory pressure, maximum expiratory pressure, and peak expiratory flow rate, all this to be closely, if it is available, spirometry to be closely monitored every fourth hourly, and MET to be followed. And here the patient saturation was going down, and they might have started on oxygen, thinking that it's a oxygenation problem. So basically, ventilation problem because of hypoventilation. Saturation was going down, and they were just keeping the oxygen. So that also might be the reason. So we have to be very closely, clearly monitor this patient fourth hourly, this respiratory parameters, and you don't just give oxygen. We need to monitor ABG in case not. So almost ICU level monitoring should be available in wards also. Okay, and this patient also having pneumonia, possibly basal atelectasis because of diaphragmatic issue, that diaphragm involvement and worsening of dependent pneumonia, and anemia also added. So many other factors also there. So basically close monitoring, and need to understand this is a high ventilation problem more than oxygenation problem. Okay, so that might be the things we need to monitor.
Any the prognostic models? I think last question, probably I think previous completion, especially prognostic point of view. Any prognostic models that you know of?
For prognostication of the patient, we use IGRIS outcome scoring, sir, in which we will be able to tell the patients of the ability to walk, at what time they'll be able to walk, and what to expect. And usually, they take into consideration the bulbar weakness and the progression, the onset of the bulbar weakness, the progression of the muscle weakness, and the uh, MRC scoring.
Yeah, that is mostly whatever you told is most of the times it's severity scoring, but there is EGOS. So something like Erasmus GBS outcome scoring, where they look at even they
Age
take
of the
into
patient.
consideration age of the patient, any diarrheal illness, and then MRC some scoring. So depending upon that, you will be able to tell how much likely the patient is going to die. But because these patient day in day out suppose comes, the counseling part plays a very crucial role. Especially they ask you what is going to be the outcome, whether they will recover better. Most of the guidelines say most in time they come and you started the therapy, 80% of them recover. 10% of around 10 to 20% of them they go very bad. Around 5 to 6%, despite you do everything, they may eventually die. But most of the complications happen when the patient is getting recovered. Actually, that is one thing which you have to keep in mind. So you have to tell the attendants that the battle is still not over. Possibly you will have these all possible complications, especially hemodynamic is the autonomic dysfunction still going to come up to, because the nadir of illness is up to 4 weeks. Probably initial 2 to 3 weeks, still there is going to be fluctuations in their course of the illness. So that is one thing which is very important prognostic point of view. I think we covered everything possible. Ravi, I think.
Yes, sir. Most of the things have been covered. Two things. One is, when do you suspect CIDP? And is there any, acute onset CIDP? When will you think of it?
So CIDP is usually if the weakness is progressing beyond the 8 weeks, sir, then we diagnose it as CIDP. There sometimes there can be an acute on CIDP where the patient's weakness progresses acutely in a background of already existing CIDP.
So, like
So-
what you have said, in the background of CADP, there will be fluctuating weakness where there is transient improvement, which will be confusing with the picture of treatment-related failure in a case of an AADP. So, the only role of steroids is in
CADP, sir.
CADP. Yes. I think most of the things have been covered. I think you have done, well. Good preparation. Most of the answers were discussed elaborately. I think that was a really extensive session, almost close to 1.5 hours. Yeah. Yes. Sir, anything, sir? Rajendra, sir? Sir, your voice, sir.
As an ICU specialist, the most important thing is vitals and oxygenation, how the bulbar involvement is there or not, the rapidity with which the patient is deteriorating. We need to closely watch them and support them. And other causes to be rapidly ruled out, because many things like spinal cord injury and transverse myelitis, the treatment is different. Steroids may be the role, they may have role in transverse myelitis and other neuromyelitis optica, MOGAD and other things, different treatment. So we need to very fast, once the patient is stabilized and airway reflexes are assessed and patient ventilation parameters optimized, rapidly we need to understand the pathology and accordingly we need to treat it. Okay.
Suppose you have a patient who has an acute onset, and unfortunately your CSF which you've done in the first week is inconclusive, and you have a NCS probably which you're not very sure where it is. Most of the times sometimes you get an inconclusive report whether it could be GBS, it could not be GBS. So is there any other method other than clinical or ruling out, where you can prove that it is most likely GBS?
Clinically, I think areflexia is very...
No, other than clinical, because clinical probably will be your clinching, because most of the times you diagnose it clinically and probably supported by CSF or an NCS. But sometimes
antibodies.
Yeah, that's where I was coming. Any particular antibodies which are
Antibodies, the anti-GM1 antibodies, the GD1A, the GT1A, the GQ1B.
Yeah, GQ1B is for
Miller-Fisher and
Miller-Fisher. Because although clinically, classically described as ascending paralysis, but we have seen patients of GBS who have presented with descending paralysis actually. So that is where it will be very conflicting. Whether you are convinced, the family has to believe you. So sometimes an objective evidence might be required to prove that it is possibly a GBS.
Yeah, there are sometimes around 10% of the patients across different studies say sometimes they may present with descending paralysis also in these patients. So that is the reason, more so sometimes laboratory confirmation like the autoantibodies. So may have to be sent. I think other than that, I think you both did well. Probably if I want put my last comments on, especially the exam point of view to students, most of the times, you prepare well. The problem is focused assessment, focused way of telling the answers is very, very important. So always think whatever you are presenting, is it relevant to the case you are presenting? So one point where what we were discussing, suppose there is no need for IVC assessment. So don't tell that unnecessary, don't drag into that area where it is not necessary. So focused way of history taking, arriving at differential diagnosis, what are the different labs used and what is the workup? How do you manage these patients? What are the different complications? Regular disease focused approach with regular ICU management, focus something like fast beats or whatever. Keep all these things in mind and go in a focused way, because always that is less time you will get in a examination if you drag unnecessarily into the areas where it is not needed, it will take out your time and you will not be evaluated in thoroughly. So that is very important across any examination point of view, especially like DRMB and all. So I think with that, yeah, I think
Yeah,
Ravi.
probably I'll echo that. Yeah, probably I'll also echo that thought because when you're doing a focus, probably your focus of interest should be you're suspecting a case of acute flaccid paralysis. I would really would like to look at the diaphragm. That is my point of interest. And probably this patient has presented with an immobility. Probably I would look at compression ultrasonography to rule out DVT at the time of presentation because this will be important for you on a subsequent follow-up. That would be my focus rather than IVC. Probably that's what Kaladar is trying to say. So you should be focused in what you are looking and why you are looking.
ICU care, like fast hug bit, all this to be very carefully implementing on these patients. Bed so
Yeah, I think.
pressure swings.
So yeah, thank you, Faizan and Jahnavi for presenting case and for your participation. And I thank Rajendra sir, for joining us for this master class and providing his valuable inputs. And thank you, Kaladar, for joining. I think that was a wonderful discussion. Yeah, we'll close this session. Thank you, everyone.
Thank you very much.
Thank you, sir.
Thank you, sir.
So Ravi and